passed their post-graduation in the last 5 years. And today we have six speakers with us. And to tell us more about the BOS and VIROC, we have with us our current president, Dr. Gautam Zaveri, who's going to tell us about the upcoming 60th VIROC and Bombay Orthopedic Society programs. Over to you, sir.
Good evening and welcome to this BOS Rising Star competition. At the outset, let me thank the OrthoTV team led by Dr. Ashok, Shyam and Dr. Neeraj, Bijlani for doing this phenomenal work of getting this program up on air and running it very well. I would like to also thank past President Dr. Sanjay Dhar, under whose initiative this program was started, and he continues to hold it by the hand and lead it further. Let me also take this opportunity to welcome each and every one of the delegates who is here for this Rising Star competition. I think today is the arthroscopy round, and on Tuesday we are going to have the spine round, eventually culminating in the main program being held at VIROC 2025. For those of the youngsters who don't know about Bombay Orthopaedic Society, Bombay Orthopaedic Society is one of the oldest orthopedic associations in India, or in fact, it's the first orthopedic association in India, predating even the Indian Orthopedic Association. It was set up in 1965, and at that time there were about 8 members to start with, and over the years it has grown in size because of its immense contribution to orthopedics. And today we boast of almost 3,800 members. The members are from all around India and are not restricted to Mumbai alone. Bombay Orthopaedic Society conducts a number of academic events through the year, for which it is extremely famous. And these are events, especially the Bombay Orthopaedic Society courses, the basic courses, the advanced courses, are all extremely sought after. People come from everywhere to attend this meeting, to these courses, because they are so well conducted. This year too, we've had already 5 such courses: the BOS Basic Spine Orthopedic course, the Basic Trauma course, Arthroplasty and Arthroscopy courses are already over. What is in the offing is later this week we are starting the Pediatric Orthopedic course. And I would encourage those of the delegates of Rising Star who are free and wish to learn a little bit about pediatric orthopedics to attend this course. It's a 7-day course which combines cadaveric dissection with live surgery program, with workshops on sawbone models, and visit to the operating rooms of some of the top pediatric orthopedic surgeons in Bombay. There is no such course around India. It's an opportunity not to be missed. And one of the highlights of the course next Sunday, that is November 9, is going to be the live pediatric orthopedic surgery program at the Jupiter Hospital in Thane, where we will be showing 12 live pediatric orthopedic surgeries. So do make an effort to be there. Finally, at the end of the year, we have the 60th or the Diamond Jubilee VIROC, our annual scientific conference attended by almost 2,000 delegates from across the country. This year being Diamond Jubilee is a little special. Besides all our regular programs, we also have some programs for you youngsters. There is a session on how opportunities abroad and how we can develop an opportunity and take ourselves for further fellowship and specialty training abroad. So do join us for VIROC 2025. There are a lot of other interesting highlights. You can look them up on the VIROC website. Now, without wasting much more time, I would like to invite each and every one of you to to Vyrock 2025, but also wish you the very best in this Rising Star competition. In the Rising Star competition, which is going to be there, wish you best of luck and see you at Vyrock as the topper or the winner of this competition. Thank you.
Thank you very much, sir. I'd like to invite Dhar sir for opening remarks and introducing the topic today.
Thank you, Ashok. It gives me once more a pleasure and honor to be here, being part of this program. This is the third edition now. We had two successful events last 2 years, and I can welcome you all for this third edition. I also take this opportunity to welcome the judges who are all esteemed orthopedic surgeons and arthroscopy surgeons, Dr. Amin, Dr. Avinash, and Dr. Mihir. Thank you for being here. I think all of you know the rules by now. You are part of the group where we've already been giving you the rules. So I once again welcome you and wish you all the best for this edition as well. Thank you very much.
Thank you, sir. I would like to introduce the judges. Dr. Amin Rajani, my very good friend. We studied post-graduation together. He has got 2 decades of experience in arthroscopy and joint replacement. Right now, he's working as a consultant orthopedic surgeon in Breach Candy Hospital, Saifi Hospital in Hinduja, Khar. And he is one of the pioneers in unicompartmental knee arthroplasty also. And Dr. Avinash Male, he was the surgeon to teach me the first fracture and give me my first surgery when I was working under him. He has done his FRCS from UK. He is a consultant orthopedic surgeon and arthroscopy surgeon and arthroplasty surgeon in Khar, Hinduja and Lilavati Hospital, and he has his own London ortho clinic. And Mihir Patel, he's an exclusive arthroscopy surgeon and an associate professor and sports medicine consultant from Mumbai. He is associate professor in Cooper Hospital and Medical College. With this, I hand over to Ashok to take over the proceedings from here and explain the rules and regulations in little detail for the newcomers.
Thank you, Neeraj. So every contestant has been given a topic on which they have been asked to do a literature review and provide insights from recent literature. They are given 7 minutes to present their talk and 3 minutes for question and answer. I'll be keeping the time and announcing whether they have exceeded the time limit or not. So we'll just invite our first contestant, Dr. Burhanuddin. Please share your presentation and we'll start.
Can you hear me?
Yeah, we can hear you.
Okay, so I'll start. My topic for today is medial meniscus root tears, repair versus non-operative structures and patient-reported outcomes. My name is Dr. Burhanuddin Chatriwala. So why is this topic important? Why do we need to look about this? Because medial meniscus posterior root tears account for about 10 to 20% of all meniscal tears. It's predominantly in the degenerative and middle-aged old women. So what happens is that it behaves functionally like a meniscectomy. There's loss of hoop stresses, there's rapid tibiofemoral degeneration and meniscal extrusion. It also causes biomechanical failure, leads to pain, OA, and functional limitations. So the epidemiology and risk factors for these, as we can see, it's usually around the 50 to 65-year age group that peaks, and 85% is approximately around degenerative or atraumatic, and around 15% is traumatic. So we have risk factors also. It's more common in females, more common in the right knee, in varus aligned limb, and patients with high BMI. So the methodology used, the review of literature, we did a comprehensive search across PubMed, Crochet Library, Medline, and Google search using keywords, important keywords. And I compiled a structured review of 10 contemporary studies. In that, there were 5 systematic reviews or meta-analysis, 3 cohorts, and 2 techniques or guideline papers. So the key questions in the PICO. So the patients with isolated medial meniscus posterior root tears were taken. The intervention done was arthroscopic meniscal root repair. It could be a transtibial pullout or all inside repair. Compared with non-operative management, plus minus physiotherapy or partial meniscectomy. And the outcomes used were patient-reported outcomes, such as IKDC or the KOS score or Lishom score, radiographic progression with the KL score or conversion to TKA. So what we found. Now, this is a pooled data of the entire study, in that repair versus meniscectomy or non-operated. The KL progression is only 22% in the repaired column is opposed to the non-operated one, which is 66%. Conversion to TKA is only 9.8% as compared to 36%. And clinically meaningful gains consistently larger after repair. So this is a graphical representation for the same. Now, focusing on the meta-analysis itself. Now, this is the pool data of all the 5 meta-analysis that we saw. In this, there is a mean increase of 20 to 30 points on post-repair. There is decrease in 55 to 60% after repair in the OA progression. And MCID is more than 85 to 90% in the repaired studies which we saw. This is again the graphical representation for the same. Now here we'll see individual important studies which I found in my review. So effectiveness of meniscal root tear repair versus conservative therapy and adjunct therapy. This was done by Hayashi et al. In that we can see that 4 studies were taken in which the dotted line signifies the repair done. In this, you can see that only this one study can show a consistent and a significant improvement over a 2-year follow-up. Others are either stagnant or may short-term increase, but then it eventually decreases. Another study by Krivicic et al. Now, this is a comparison study between repair and meniscectomy. In this, 64.8 months follow-up was taken, mean follow-up. In that, 144 patients were there. 22% of those who underwent a repair exhibited OA progression, while 66% of those who underwent a meniscectomy showed OA progression. We can see on the graph over here. And on the other column, we can see that 9.8% of patients who underwent a repair required a TKA or a total knee arthroplasty, while 36% who underwent a meniscectomy required a total knee arthroplasty. Another study in this shows by Wang et al. Now, this is an important study because in this, they are using a medial meniscus root tear with or without a high tibial osteotomy. In this, they used inclusion criteria of 0 to 5 degrees with a mean follow-up of 2 years. However, in this study, we can see that in the post-operative IKDC scores for the orange color is only the meniscal repair, while the purple color is meniscal plus tibial osteotomy. We can see there's not much of a clinical difference in post-operative scores. Either you do a high tibial osteotomy or you do not do it. So the use of H2 as a supplement in treating MMRT for patients with severe arthritis has been found to yield a similar clinical and radiological outcomes. However, further studies required because this had only a follow-up of 2 years. Now, in this is a midterm outcome of posterior medial meniscus root tear repair. The systematic review. In this, 28 studies were taken with 994 patients total, done by Chang et al. Mean follow-up of 4 years. We can see that only 49% of patients had at least only 1 grade of increase in Kelvin's and Lawrence scale, while 23% had a cartilage degeneration at around 31.6 months follow-up. But almost 100% of everyone had at least some or significant improved clinical scores. Now let's talk about the cohort studies that we have. Now the combined or pooled data of the cohort studies, it shows that the IKDC and the KOS improvements of about 25 to 30% as compared to the non-operative. Conversion to TK around about 10% as compared to the non-operative, which is 30 to 36%. Patient satisfaction is more than 90% as compared to less than 60% of the non-operative. This is again the graphical representation for the same. And now talking about the individual data. Now this is an important study because this measures the outcomes of all arthroscopic, all inside repair versus the transtibial pullout of the medial meniscus posterior root tears. In this, there's a cohort of 28 patients in which all inside repair was done as compared to 16 patients in which transtibial pullout was done. This is followed up for 2 years. In this, we can see that there's significant improvement with the all inside repair as compared to the transtibial pullout. However, in this case, in this cohort, they did not compare it with the non-operative measures. Another study in which meniscal centralization with medial meniscus root repair was done. In this, the inclusion criteria was about more than 3 mm of medial meniscus extrusion in a follow-up of around 2 years. 25 patients were done. And that we can see that the Tegner score, the VAS at rest and VAS with use is less as compared to the preoperative stage. The KOS and the IQAC scores are also improved as compared with the preoperative. So centralization was done, and no patients had undergone a revision meniscus surgery or total knee arthroplasty at the time of follow-up. So who benefits the most? Patients with age less than 65, KL scores of 0 to 2, neutral correctable alignment or moderate BMI. Poor candidates are those with higher KL scores, fixed varus or low activity. Now, Gracia et al. Give us a algorithm for decision making. Step 1 is obviously the diagnosis. Step 2 is the cartilage degeneration, which is very important. KL showed greater than 0 to we can proceed. If it's more, then maybe we might go for non-operative or osteotomy. Again, we check the alignment. If it's less than 5, we might go a root repair, or if it's more than 5, you might only do a high tibial osteotomy with or without a root tear repair. Then we check the patient profile also before making a decision. And fifth is the post-treatment pathway or the rehab protocol. Now, when to conserve, that is also very important. Advanced degenerative changes, Kelvin-Rollins grade more than 3, malalignment, irreversible varus more than 5 to 10 degrees, low demand for elderly patients, comorbidities present, surgical contraindication. It's better to conserve these patients because they will not have a significant improvement after surgery itself. Clinical takeaways, repair is preferred for a symptomatic patient with minimal cartilage loss. Patient selection is very important. It drives the outcomes. Repair improves the patient-reported outcomes and delays osteoarthritis, but it's not a cure. These are my references. Thank you so much.
Thank you very much. Now I'll invite the judges for question and answers. Dr. Amin, you can start.
Burhanuddin, excellent presentation. My question to you is,
Thank you, sir.
How does a degenerative medial meniscus root tear? How does it tear? Why does it tear if it's atraumatic?
So in this patients with a high BMI with extremely active outcomes or athletes, they have natural wear and tear degeneration of the
No, we are
menisci.
talking about degenerative medial meniscus root tears in elderlies.
Yes, sir.
I want to have a one-line answer as to why do they tear? What do you think? Why do they have these tears, atraumatic tears?
So arthritis can be a cause for it. Can loss of cartilage viscosity, loss of fluid content of the cartilage degeneration can also cause tear of the roots in these patients.
So that is why they are called degenerative in the first
Yes, sir,
place. Because so one is a traumatic meniscus root tears, and there are degenerative meniscus root tears.
Yes, sir.
Degenerative is as in patients who have osteoarthritis. My question to you is that did you study any midterm outcomes of these repairs of these degenerative tears or long-term outcomes when you were doing your research?
Yes, sir. I found there was one study for the long-term outcomes of degenerative tears also. Can I share my presentation again for you to show?
Yes, but most of your follow-ups were 2 years or so. So
yes, so we had a 4-year outcome.
That again is
in
not
the
midterm. Midterm
meta-analysis.
would be anywhere
It's
between
not very
5.
torn. Yes, sir. Yes,
Midterm
sir.
would be anywhere between 7 to 10 years, actually, not even 5 years. And if you
Yes, sir.
see the reason why these tears happen in the first place is that these patients already have osteoarthritis. So we
Yes,
need
sir.
long-term follow-ups of these patients to justify a repair in these patients. Because personally, as
True.
an arthroscopic surgeon, I don't
Yes,
know
sir.
about Mihir and Dr. Avinash, but we have burnt our fingers operating such tears in osteoarthritic patients, and these patients are not happy. So the message that we want to give to the audience is that if the tear is because of degeneration and there is wear and tear, it is better to conserve, no matter what the
Yes, sir.
early literature says. But that is not the point that you are giving in your presentation. So that is why I asked you this question.
I'm sorry if it came out like that, sir. But my idea for this presentation was to show that the outcomes of repair were better as compared to conservative. However, like I said, most of the cause of the tear is atraumatic or degenerative. They haven't specifically mentioned how the tear was done. Was it traumatic or degenerative in these studies which I went through?
Exactly.
Yes, sir. Yes, sir.
Yeah, hi. Badruddin, a great presentation.
Thank you, sir.
A lot of articles reviewed. I just want to make one point. You showed a slide about the criteria for conservative treatment, so which
Yes,
is
sir.
fairly generalized one. So
Yes, sir.
what I want to check with you is that did you focus on the clinical presentation of the patients who were subjected to the surgery? Because you have given the age less than 65 years, you're free to operate, otherwise non-operative treatment. But in a meniscal surgery, non-operative treatment is not the only criteria. We get a lot of people, as Amin pointed out, who have
Yes, sir.
meniscal tears, who have mechanical symptoms, where they have a root tear, they have OA changes going on, but they don't need a knee replacement. You sort the
Yes, sir.
meniscus out, and the problem is sorted for at least a couple of years. It may be 5 years, 7 years.
Yes,
So that point is very important. A patient with
yes,
an
sir.
arthritic knee with mechanical symptoms merits an arthroscopy, regardless whether he's going to have a knee replacement in the future. So the criteria
Yes, sir.
cannot be very diffuse. You have to
Understood, sir.
kind of refine them depending upon the mechanical symptoms. That's the only point I want to make. And you excellent presentation.
Thank you, sir.
Yeah, Dr. Chatriwala, my question. Could you
Yes, sir.
classify root tears for us?
So, classification of root tears. So, it can be based on the location, can be anterior or posterior or medial or lateral. So then we have, I had,
That's fine, no problem. That's fine, no problem. So basically,
if
my
I
question
can't
was,
forget the name, I
that's
can't
all right,
recall
no
the
problem.
name of
So
the classification, sir.
my
But there are
question
5
was
types.
basically
Yes, sir.
classification of the posterior root of the medial meniscus tears. Anyhow, so the second question is, one of the slides that you presented said that you do a root repair in a patient with varus, you do an H2 or don't H2, there is no difference. But you did not quantitate the amount of varus that were discussed in the study. So there must be kind of cutoff after which you would recommend an HTO when you do a root repair. So anything you can highlight a little picture on that?
Yes, sir. Yes, sir. In my presentation itself, I had written that the inclusion criteria was varus of 0 to 5 degrees in which they considered it with a medial meniscus root tear repair. But beyond that, they had considered only a HTO. That's why in the protocol also, which is confirmed by Garcia et al., they have said that only with less than 5 degrees of virus, they would consider root repair. More than 5 would only primarily be a high tibia osteotomy. With maybe if required, you can do a root repair, but the majority would be a high tibial osteotomy, sir. More than 5 degrees of varus.
Okay. And the third question is,
Yes, sir.
when you say that the results are good, are there any clinical results or is there any evidence of root healing?
So in most of the studies which I've reviewed, I haven't seen the surgeons going for a follow-up arthroscopy in 6 months or at follow-up. They've mostly done patient-reported outcomes. And since my topic was also just focusing on patient-reported outcomes, I stuck to that in the PICO which I did. So my slide in which I showed the outcome, I stuck to patient-reported outcomes also because since that was my topic.
Yeah, good.
Thanks a lot. Yeah,
Ashok,
Ashish or Dhar, sir, any questions? Ashish, go ahead.
Yeah, Burhan, good presentation. I just wanted to know, since
Thank
you
you, sir.
presented literature review, which the top 4 articles, where are these authors from? What kind of journal is it published in? And are any of these surgeons or the centers which have designed the surgery?
So in my references, so most of these surgeons are from outside India. They're so Hayashi et al., Chiang et al., Wang et al. Also, they are mostly Korean surgeons, sir, and they've published in the BMC journal, sir, and the arthroscopic journals. In a specific journal.
So what I'm trying to ask is that these journals,
Yes, sir.
KBJS, Clinical Orthopedics Related Research, Journal of Arthroscopy, ISACOS Journal, are any of these articles published in these high impact articles which we as orthopedic surgeons refer to?
So not in the ISACOS journal, sir. It's there in the BMC journal, and so it's within the local journals of their respective countries also.
Okay. And are these Korean surgeons or from very high volume arthroscopy centers, or are these from China?
No, so they're from Korea, but I did not verify their work profile or the volume of work they do, sir?
So that's fine. That's fine. I
Since
mean, next
they
time when I hear this presentation, I would like you to also come
understood, sir.
a little bit that okay, this is a surgeon who has sort of designed this technique and this is
Understood,
his
sir.
experience, things like that. It changes how we interpret their understanding of the paper.
Fair. Yes, sir. Understood, sir.
Sir, any questions?
No, not really. Thank you.
Okay. Thank you, Burhanuddin. And I'll invite the next candidate now. Dr. Rahul, please load your presentation. We can go ahead with you.
Thank you, sir. Just
You can start. We can see your slides.
Good evening, sir. Can you hear me?
We can hear you.
Okay, today my topic is ACL reconstruction with LET augmentation in high risk knee, indications and outcomes. So my name is Rahul Sreenivasan. I'm working as assistant professor in Gun Medical College, Trivandrum. And ACL injuries are common in young pivoting athletes. So standard ACL reconstruction in patients less than 25 years result in 7 to 14% of failure. Persistent rotational laxity leads to graft failure. LET augments rotational control, decreases graft load. So even with anatomical ACL reconstruction, pivot shift persists in 30 to 40% of cases. The risk factors are high tibial slope, laxity, young age, early return to sports. So there's a clinical gap identifying who benefits most from LET augmentation. So objective of my talk is to identify evidence-based indication for adding LET to ACL reconstruction, to summarize clinical and biomechanical outcomes in high-risk knees, to evaluate safety profile based on recent RCTs and meta-analysis. So LET reinforces anterolateral structures, restores control of internal tibial rotation. Common technique is used is modified lamella iliotibial band strip anchored posterior and proximal to lateral epicondyle. This prevents excessive graft tension during pivot loading. Lateral extra-articular tenodesis technique and femoral tunnel placement is shown in the picture. Coming to the indications, evidence-based is a high-risk profile cases like age less than 25 years, then pivot shift grade more than or equal to 2. So third one is posterior tibial slope more than 9 to 12 degree and generalized laxity or hyperextension more than 10 degree. And fifth is the revision ACL reconstruction or meniscal deficiency. And sixth is pivoting or cutting sports like football, kabaddi, basketball. Coming to radiological indicators, posterior tibial slope more than 12 degree increases the ACL graft load or failure risk. And second fracture of lateral femoral notch sign, that's a marker of anterolateral injury. MRI anterior tibial translation more than 7 mm result in functional laxity or high risk knee. So stability one trial by Jedgood et al. In AGSM 2020 and Gisakos 2023 update states an RCT on 618 patients aged between 14 to 25 years. The graft rupture occurred in 11% of patients with ACL reconstruction alone versus 4% in ACL reconstruction plus LET. So there's a 67% risk reduction. There's no increase in infection, stiffness, or OA at 2 years. There's a slight increase in hardware removal, 3%. So there's a level 1 evidence that LET is safe and effective. There's a biomechanical insight in Lemay et al. In AJSM 2025. increased posterior tibial slope, higher ACL graft forces and translation. LET reduces graft load by 22 to 37%, similar to slope reducing osteotomy. Improves stability in high slope knees without added mobility. So clinical outcome summary. From the Get Good 2020 et al. Study, RCT, it shows LET reduced graft rupture by 67%. And Feller et al. In 2021 showed 74% of the patient ACL with LET returned to sport. And Validate 2025 et al. Showed LET is a cost-effective, and Mishra in IGO 2024 et al. Showed improved knee scores. And coming to complications and safety. So there's a mild lateral pain or hardware irritation, about 3 to 5% of cases. And no increase in stiffness or osteoarthritis 2-year follow-up. So over-constraint avoided with correct femoral tunnel placement. And overall, reoperation rates are similar between ACL reconstruction alone and ACL with LET procedures. So Indian clinical context, high prevalence of generalized laxity and early sports resumption in Indian population. So there's a variable assessed to structured rehabilitation in India, higher re-injury risk as per the evidence. So LET is cost-effective, reproducible, and protective in these scenarios. So when to add LET clinical algorithm? So if the patient age is less than 25 plus pivoting spot, yes. Revision ACL reconstruction, yes. Pivoting shift more than 2 grade, yes. Posterior tibial slope more than 9 degree or hyperlaxity, yes. Non-pivoting spots and more than 30 years, no need of LET. So take home message, LET plus ACL reconstruction, 60 to 70% lower graft failure in high risk knees, safe, effective, and reproducible, indicated in young pivoting athletes with risk factors, no increase in complications, standard adjunct in Indian high risk knees. Future directions, long-term 5 to 10 year comparative data with ALL reconstruction, sensor-based pivot shift quantification, Indian multi-center registry to evaluate real-world outcome. Acknowledgement and references are Get Good et al. In AGSM, Lemme et al. AGSM, and Validate et al. XCO, and Feller OGSM, and Mishra et al. In IGO 2020. Thank you.
Thank you very much. I invite the judges for questions. Amin sir, you can start. Dr. Mir, you can start.
Yeah, Dr. Rahul, can you hear me?
Yes, I can hear you, sir.
Rahul, a very good, concise, crisp discussion on LET. Now, if you are suggesting from your review that LET is so good, what would be your comments to my question mentioning why shouldn't we add LET to all ACL reconstructions?
I have mentioned that LET is needed only in high risk knee and less than 25 years of age, or those are involved in pivoting sports, and those cases with ACL revision surgeries, and those who have a risk for retear or grade 2 in pivot shift test.
Dr. Rahul, that's absolutely fine. So, for example, if a 35-year-old patient, how would he be different from a 25-year-old patient having an ACL tear?
With a pivoting sports, if he is participating, if he is
No,
not going.
Let's talk about the age, because your first criteria very specific was a patient less than 25 years. Okay, so let's have a patient who has a pivot, but same thing, but there's a patient who's 25 and a patient who's 35.
As per the literature review which I have done, they have done a study less than 25 years. Their study is done, and they say it is high risk in 25 years. Rupture rate is 4 to 12%. There's no clear-cut literature review regarding 35 years old.
Okay, and my follow-up question to the same question is, what would be a downfall of doing an LET?
I didn't get you, sir.
A possible complication of doing an LET with an ACL reconstruction. So a given procedure will always have something.
The tunneling, if not correct, it can result in failure. Irritation of the implants is one complication.
Okay.
the more stiffness can result if not tunnel is not properly placed.
Okay, great. Thanks.
Uh, Dr. Rahul, right?
Yes, sir.
Yeah, Dr. Rahul, Dr. Amin Rajani here. I have only one question for you. First of all, let me congratulate you on an excellent presentation. You spoke
you.
very crisply and your slides were very much in detail, and I really liked the way you presented.
Thank you, sir.
My question to you is a patient with hyperextension. Now, generally, in our practice, if a patient is in hyperextension, we'd rather keep him in hyperextension than to make it neutral, because those patients are never comfortable making them neutral. Because the other leg is also generally in hyperextension. Now, when you do an LET, you tend to, kind of make that hyperextension to neutral. What would you want to do at that point in time to avoid that, neutralization of the hyperextension?
In the literature I reviewed, they says to keep the to do LET in case of hyperligament laxity or hyperextension cases, but to fix it in such a way that you maintain maintain the leg comparable to the opposite limb while tightening the final screws.
Which one?
That's
The ACL or the
only one article has mentioned this mainly. No other article has mentioned regarding hyperlaxity. I didn't see. So actually, I didn't see, sir, in my literature search. Only in one article I have seen that to maintain the same hyperextension after you can tolerate. It should not make it into pure neutral or flexion. The extension, hyperextension should be or would come to a neutral, should not be in flexion while tightening the final screws.
And have they done any comparative study between a patient with hyperextension undergoing an additional LET comparing to that a patient undergoing having hyperextension, not undergoing LET, and just a single ACL reconstruction? Has there been any study like that which you have reviewed?
Yes, sir. They have done compared patient with hyperlaxity with ACL alone and LET, and they said doing LET is better in such patients. Better in such patients. That's the only wordings they have given in literature search I have seen.
Meer, would you like to comment on that for the?
No, I mean, I think for this forum, I think this is enough question and that's a good answer.
Okay.
Avinash, sir, you have any questions?
Just one question. I mean, just one question on my part. It was a great presentation. You summarized
Thank
it.
you, sir.
You mentioned about age less than 25 years who are at high risk. Have you come across any articles where the adolescents have a higher risk of undergoing failure of the ACL compared to a generalized younger age group? Because there have been very clear articles where have you read anything like that where the adolescent group is more to be subjected to this procedure than a young adult? I mean, even Mihir is open to comment on this, or Amin, but I would like to know what are your thoughts on it, Rahul?
I searched through the PubMed using Boolean words and ACL with LET and without LET. So in that, I didn't come across anything saying adolescents have high failure rate, but less than 25 years as high risk articles are there.
Yeah.
So I think Avinash, he's doing fine.
Okay, any other questions? Ashish, Dr. Dhar?
No, I think it was a good presentation. The only thing I would like to know is that you have presented good papers from good journals and good authors. I really appreciate that. Very crisp presentation.
Thank you, sir.
Can you tell us what are the approximate numbers of patients these studies are talking about? Are these like, less than hundreds or more than hundreds for a long period of time?
So first RCT is 618, and the last Indian journal I told is 60. The rest everything is more than 100.
Great. Thank you.
Thank you, sir.
Ashok, I think we can proceed.
Yeah, I'll thank Dr. Rahul, and invite Dr. Siddharth for his presentation. We can see your slides. Make it full screen and we can start.
Yes. Good evening, everyone. My topic for today is Bankart versus Letache procedure in athletes, recurrence and return to sport. Uh, First, I would like to talk about importance of recurrent shoulder dislocation in athletes. It is especially commonly seen in contact and overhead sports and can adversely affect the performance as well as the current longevity. It is not anatomic limitation, but it is a functional limitation as well. And the key target, which we should focus on management, is to restore the stability and to ensure a safe and early return to play. The two main surgical modalities are arthroscopic Bankart repair and open or arthroscopic Lataje repairs. So the objective of my review is to compare them in athletes with respect to recurrence and return to sport outcomes. And the choice must balance between the recurrence risk, sports demands, and performance recoveries. This is the methodology which I have used, screened through PubMed databases and Google Scholar, systematic reviews and analysis and sources in the past 10 years. In this meta-analysis involving 874 athletes, I found out that Bankart and let us say both have a high return to sport ratio with a significant difference in the rate of return to play time. But Bankart repair was 4 times more likely to result in recurrence. This is another systematic review which I did, and in which a algorithm is found out, in which in the cases of recurrent shoulder dislocation, uh, how they have given is initially assess the patient, do radiographs and MRI, and if the main decision, the point I would like to emphasize on is that in the operative management, if there is less than 13.5% bone loss with on-track Hill-Sachs lesion, then you go for an arthroscopic Bankart repair. And if there is 13.5 to 20% bone loss, which is the range of subcritical bone loss, or more than critical bone loss, which is more than 20%, then bony augmentation procedures are required. Uh, this was the paper which mentioned the on-track, off-track Hill-Sachs lesion. For the on-track Hill-Sachs lesion, Bankart repair, and for the off-track Hill-Sachs lesion, bony augmentation procedures such as a Lataje or a remplissage should be done. This is another article published in the Journal of Shoulder and Elbow Surgery. So in that, it was a cohort study of conducted for 120 athletes. The results which were found out was that being 20 years old or younger was a risk factor for the recurrence, and the risk factor or the risk of recurrence is significantly higher for Bankart procedures than Lataje. And the mean return to sport in the Lataje procedure was 5.1 months as compared to the Bankart procedure, which was 6.4 months. So this article concluded the risk of recurrence as well as the return to sports is faster in Lataje procedure than in arthroscopic Bankart repair. Another article which showed the cohort study of 73 rugby players, in which 84 they were operated for arthroscopic Lataje procedure, and 84% of the players returned with a to play again with a period of 6.6 months, and return to play was achieved in almost all cases with low recurrence rates. Then there was one more meta-analysis which had 21 clinical studies, total big sample size of the shoulders operated, which showed arthroscopic Bankart repair again to have a high 3.0 times high risk of recurrence and revision. And the row score was higher in the Lataje group by an average of 4.55 points. And this was an article which emphasized both, which included the normal population as well as the athletes in the study. but the total complication rate was 47% lower in the Bankart group as compared to the lethargic group. And I found out another article about anterior shoulder instability in the teenage, which showed that it was actually a systematic review of key articles on anterior shoulder instability in the teenage athletes. And this shows that the teenagers are more predisposed to higher risk of recurrence after the first dislocation episode, and also have a higher risk of developing an off-track Hill-Sachs lesion. And there is a growing shift towards remplissage and lethargic procedures because the arthroscopic Bankart repair, it has high failure rates in such group. So I would like to conclude by saying that these are the advantages of arthroscopic Bankart repair are that although you can give an anatomical soft tissue repair, preserving motion, it is less invasive, but every procedure has its advantages and disadvantages. The disadvantages are that the recurrence rates are higher, and the decision of when to choose depends on the glenoid bone loss and the on-track, off-track Hill-Sachs lesion. So if the Hill-Sachs lesion is on track with less than 13% glenoid bone loss, then to prefer arthroscopic Bankart repair. And if the glenoid bone loss is more than 13 or 20% with an off-track lesion, then to go for a lethargic procedure. This I could conclude from my review, and these are my references. Thank you, sir.
Thank you so much. I'll invite the judges for their questions. Dr. Amin, you can go ahead, sir.
Nice presentation. I just want to ask
sir.
you, I mean, in your entire presentation, when you've been talking about arthroscopic Bankart repair versus lethargic, very few times you have mentioned that the arthroscopic Bankart repair is also done in combination with a remplissage. And there has been no comparison between arthroscopic Bankart plus remplissage compared to a open and an arthroscopic lethargic. So I want to ask you only one question is that when you did your research, was it only a Bankart repair in those patients or was it accompanied by a remplissage procedure as well?
So it was mostly only a Bankart repair. My topic focused on Bankart versus lethargy. So that is what I mainly focused on, sir. But the studies didn't show the remplissage combination of Bankart with remplissage.
It is remplissage is a procedure which is like a LET with
Yes, sir.
ACL, so it
Yes,
goes
sir.
hand in hand. So when you're doing a comparison with an arthroscopic soft tissue procedure, the Bankart repair and the remplissage go hand in hand if you have to compare it to a lethargy. This is what I believe in, but
Yes, sir.
the other judges are free to comment.
Yes, sir.
Siddharth, some questions from my side.
Yes.
So from your talk, I understood that most of the figure studies that you've done in the last 5 years, which you've reviewed, the figure has come to about 13.5% as glenoid bone
Yes,
loss,
sir.
which is like a cutoff where you shift from an arthroscopic Bankart's repair to a bony augmentation. Am I correct?
Yes, yes, sir.
Yeah. So how is this bone loss calculated?
So the bone loss is calculated by a formula, which is point. You measure the distance of the glenoid rim from anterior to posterior, and subtract the glenoid bone loss from it, and then accordingly calculate 0.83 into the difference between both of them.
Are you getting confused between glenoid track Hill-Sachs index? I'm asking about how do you calculate the bone loss of the glenoid preoperatively?
Okay, sir.
I think you are
Sorry,
confusing
sir.
with calculation of the glenoid
Yeah.
track and the HSI.
Yes. Sir, preoperative CT scan is highly recommended, sir.
Oh, so you
And
recommend a CT with MR for all these patients?
yes, sir. To assess for the glenoid bone loss, CT with MR, sir.
Okay, so would the decision-making change in a patient who has a glenoid bone loss versus a bony Bankart?
You know, so as for the person who has a glenoid bony loss, if it exceeds the subcritical or the critical point, that is more than 13%, sir, actually more than 13% glenoid bone loss would be a gray zone situation, because then also you will have to see for the Hill-Sachs lesion. If the Hill-Sachs is off track along with it, then there are higher chances of instability, higher rates of recurrence. So in those procedures, sir, preferably a bony procedure would be recommended, sir. And if it is more than 20%, then straight away we can think about either. Yes, sir.
Fine. Okay, thanks.
Yeah, Dr. Meir or anyone else.
Avinash?
Yeah.
Yeah, Ashish, go ahead.
Yeah, Avinash wanted to ask.
Siddharth, just one question. Very basic
sir.
question I'm asking. Your younger brother is a football player who
Yes, sir.
keeps on dislocating his shoulder, and he has a Bankart's lesion. Would you prefer
Yes, sir.
to have a Latarjet procedure or a Bankart's procedure? Do you think Bankart's is the primary procedure he should have, or Latarjet is a salvage procedure? I'm asking you a practical question based on your.
Yes, sir.
You have done a lot of literature review.
Yes, sir. Sir, if he's a case of recurrent shoulder dislocation, so then uh, preferably, sir, first I would like to investigate him for and get a CT and MRI done, sir, to assess for the glenoid bone loss, sir. And because you mentioned that he has dislocated his shoulder multiple times, sir, so preferably in such situations, Latarjet procedure would be
So you'll do a primary
recommended.
Latarjet?
Yes, sir.
Siddharth?
Yes, sir.
Yeah, the two aspects to this question. When you did your literature review and literature search, did you realize or did you think that there was a visible divide between papers coming out of North America and papers coming out of Europe in their bias towards going towards Latarjet or they say a Bankart's with Remplissage? And the second part was an extension to what Dr. Avinash wanted to ask as a general orthopedic surgeon. If the recurrence rates are actually less in a Latarjet, you're assuring us of no further dislocation after a Latarjet. Why not a Latarjet in the first place? And why not get rid of the Bankarts completely as a procedure?
Yes, sir.
Why should all of us not start doing a Latarjet procedure?
No, yes, sir. Sir, addressing your first question, sir, while doing the review, sir, I could find that there was an obvious drift because, sir, my topic mainly focused on recurrent shoulder dislocation in athletes. When I did the review, it primarily focused more towards, it was more in favor of Latarjet procedure, sir. Sir, and sir, secondly, to addressing in your second question, sir, uh, sir, Latarjet procedure is also an open procedure, sir. So it has its because it has higher morbidity, sir, and there are more chances of infection. So because of that, sir, an arthroscopic Bankart repair in cases where the glenoid bone loss is less, sir, would suffice.
No, so based on your literature review, did you find that the Latarjets were associated with higher risk of complications? That's what I'm trying to ask.
Yes, sir. In one article which I shared, sir, review, there was a paper which mentioned that in a meta-analysis that Latarjet procedure had higher complications, sir.
Okay, as regards the question, that's it. I mean, I'm done with the question.
Okay.
I would like to know what Amir's view. I mean, would you agree that people are now warming up to the idea that Latarjet actually might be a good procedure, more easily offered to patients than what was done 10 years ago? Then they used to reserve it only for the failures or only for the recurrent Bankarts.
I think Neeraj.
Anyway, that's for later. We can proceed.
Okay. Thank you, Dr. Siddharth. I'll invite Dr. Hitarth for his presentation. Dr. Hitarth, you're here? Yeah.
Yes. Hello, sir.
Yeah, go ahead. Share your presentation.
Yes, sir. Is my screen visible?
Yeah, screen is visible. You can start.
Yes. Good afternoon, everyone. My today's topic is all inside meniscus repair devices, its indications, and its failure rates. So historically, partial or total meniscectomy were the only treatment option for the meniscal tear. However, current literature shows that both meniscectomy and repairs have similar short-term outcomes less than 2 years in patient-reported outcomes. Repairing the meniscus restores the joint biomechanics and has a better long-term prognosis. So there is overwhelming literature that currently supports meniscus preserving surgery. The current phrase "save the meniscus" is no longer a slogan, and it has become a mandate in the current days, which is backed by multiple systemic reviews and editorials. So the three basic methods of meniscus repair: the inside out, the all inside, and the outside in method. This review article suggests that inside out meniscus repair is a versatile, cost effective technique and remains the gold standard for management of most meniscal tear patterns. So does this currently stand true? So the aims of my study were to review the evolution and current indications of all the meniscal repair devices, evaluate the failure rates and the clinical outcomes, compare outcomes and the complications with other methods of repair. So the methodology I used was electronic databases, PubMed and Google Scholar with a filter of last 10 years, a reference list of all the other articles, the level of evidence 1, 2, 3 were selected, randomized controlled trials, meta-analysis, systemic reviews were included, and studies with high citation index were chosen for the final review. So evolution, the all inside devices were first introduced by Morgan in 1991. The first generation devices were curved suture hooks, which had to be passed by accessory portals. Second generation devices were rigid implant-based devices, which were aerodarts and fasteners, which included them. Third generation devices were suture and anchor-based devices, which allowed ability to retension. And fourth generation are the current generation, which is available are all suture devices, the knotless systems, and the flexible devices. So the benefits of all inside repair devices: it restores tissue continuity without fixing the meniscus to the surrounding soft tissues. It avoids hyperstability, which can lead to suture breakage or re-tear. And it avoids the risk of inside-out repairs such as vascular compromises, knot irritation, and nerve injuries. It also reduces operative time, faster post-op recovery, and there's no need of a extra incision. So the two biomechanical studies that have been given here, the first study was given by Dr. Alan Barber, which suggested that peak all-inside anchor devices had similar biomechanical results to the inside-out techniques, but he only considered the failure loads of in the study. The second study done by Marchetti, it was a biomechanical study which took in consideration the total contact area, the mean contact pressure, as well as the peak contact rates. Both the studies had both the methods of fixation had similar results, and there was no difference between the two methods of fixation. So the indications of the meniscal repair, all inside repair can be given by laterality, the tear pattern, the concomitant ACL, if there's a concomitant ACL repair that has to be done, and the activity level of the patient. So first, this study done by Adam Miller, which states that in all inside technique, the medial meniscus failures were way higher than the inside out techniques, but the lateral meniscus repairs had similar failure rates in both. However, this study did not consider radial tears and in the study. So in radial tears, the study given by Gelly considered radial tears of the mid body of the lateral meniscus. In this study, there were no significant differences in load to failures between the inside out and the all inside tears. However, another study mentioned here has given which included both medial and lateral meniscus repairs, gave better improved patient reported outcomes in all inside. However, inside out gave a higher failure rate. In bucket handle tears, in study given by Samuelson, this is a clinical outcome study which gave no significant difference in Tegner score, IKDC scores, and range of motion between the two groups. However, the overall failure rate after all inside meniscus bucket handle repair were 29.3% at an average of 13 months, an average of 13 months. With ACL reconstruction, with concomitant ACL reconstruction, Westerman performed the study. Westerman reviewed the study and he gave the inside out meniscal repair performed in ACRL had a mean failure rate of 10% in over the 2 years, and all inside meniscus repair had a failure rate of 16%, which was clinically significant. In athletes, comparing the both all inside and inside out repairs, the failure rates were not significantly different. However, re-injury rates were significantly more in all inside devices, and return to play were significantly higher in the all inside devices. So indications for all inside repair, there are no absolute indications for all inside repair over other methods. We can conclude the relative indications by reviewing the literature generally, which can be lateral meniscus, radial tears, the tears in athletes, and all other lateral meniscus tears from mid body to the posterior horn can be the relative indications. However, other meta-analysis for isolated meniscus tears also gave similar outcomes in both of the medial and lateral meniscus. So the conclusion, both all inside and inside out techniques achieve comparable functional outcomes and functional and clinical outcomes when proper indication and techniques are followed. Failure rates tend to be slightly higher in all inside repair, particularly in medial meniscus tears. Inside out repairs, while biomechanically strong and versatile, carry a greater risk of neurovascular injury and extraarticular knot irritation. And choice of technique should be individualized, guided by tear pattern, location, surgeon expertise, and available equipments and costs. These are my references.
Thank you very much. I'll invite the judges for their questions. Dr. Mir, you can go first.
Yeah. So just taking off from the very last line of your conclusion, you said that it is well indicated in a certain tear, a certain position. So could you tell us which is the ideal location and which is the ideal tear pattern or configuration for which these all inside devices should be used? The ideal.
So the ideal pattern would be a lateral meniscus radial tear, which according to the meta-analysis, they have a better outcome than the all inside devices. It reducing because of it has lesser complication rate, and also in athletes they have a lesser complication and failure rates in the generally the lateral meniscus radial tears as well as the posterior horn and the mid horn tears.
So, Dr. Gathani, could you enlighten us why these devices work better on the lateral side? Because there are multiple slides that you said that they work better on the lateral side than on the medial side.
Yes,
So,
sir,
when you
because
went to the studies, was there a specific reason why they work better there and not on the medial side or lesser on the medial side?
yes, sir, because lateral meniscus is more mobile, is a more mobile structure than the medial meniscus, and the inside-out device generally tend to fix the meniscus to the outer structures and up to the capsule. So if there is a problem of over constraint with the inside-out devices in the lateral meniscus.
Okay. And my last question is you spoke about a certain study mentioning about peak devices.
Yeah.
So
Yes,
are
sir.
there any other devices in recent times that can be used for an all inside repair besides peak?
Yes, sir. We have now we have the all suture devices which have come up, which are used for inside out.
Okay, great. Thanks.
Yeah.
Yeah, go ahead. Sir Avinash.
Dr. Gathani, nice presentation.
Yes,
What
sir.
I
Thank you,
liked
sir.
about your presentation is that you've covered almost everything as far as meniscus repair is concerned. What I want to ask you is during your research, did you come across any article which compares an all inside along with inside out technique for bucket handle tears, having a much better outcome compared to just an all inside device? Or
Sir,
compared to just an inside out repair, two individual technique repairs and a combination of both the techniques. Was there any comparative study with that?
yes, sir. The comparative study for bucket handle tears uh, shows shows that there were uh, it was the results were equal for there was no significant difference for the all inside and inside out
No, sir, you did
repairs.
not get my question. My question is, was there any comparative study which compared a combination of these two techniques or three techniques, inside out, outside in, and all
Okay,
inside as
okay,
one group, and
okay.
individual each of them as the other
No,
group?
sorry, sir. No. I got your question, sir. No, I did not come across it.
Okay. Generally, all inside devices, where do you think, in which part of the meniscus are they better used? I know you answered the question about the tear,
Yeah.
but I want to ask you, if a meniscus is 180 degrees, if you see it as a C shape, which is the area which is most suitable for an all inside device?
And, uh,
And which is
the-
the area which is more suitable for an inside out device?
so for all inside, it would be the area between the posterior and mid horn, the area, and for an all inside out, it would be the posterior horn, so the proper
Sorry,
posterior
come
horn.
again. For the inside out, it will be the posterior horn.
Posterior horn, yes.
Okay. Okay. You're talking about the lateral meniscus or the medial meniscus? Both, or you're talking about both?
So, medial meniscus, uh, so both, generally both.
Actually, it is the other way around, because all inside
Okay.
devices are more used towards the posterior horn, uh,
So,
and and the inside out techniques may be used towards the posterior horn, but ideally should be used between the mid and the body for safety concerns as well.
yes.
Yeah.
Yeah. Okay.
Thank you. Thank you.
Thank you.
Avinash, sir.
Hey, no questions. Fine.
Any questions, Ashish? Dhar, sir?
No questions from my side.
No questions.
Yes.
Okay. Thank you, Hitarth. That was
Thank you.
a
Thank
nice
you, sir.
presentation.
Thank you.
I'll invite the next contestant, Dr. Soham, for his presentation. Soham, please share your presentation. Okay, make it full screen and we can start. Click open with and open with a PPT. This is opened in a browser. So you have it downloaded on the laptop? Open from there.
I have downloaded, sir. I am not seeing the
Yeah,
document.
open through the PowerPoint, not through our browser.
Is it visible, sir?
It's still opening. It will open. Has it opened at your end?
Yes, sir. It has opened at my end.
So then you have to share the screen where it is open. Now it is sharing the desktop, I think. So stop sharing. Start sharing again and find the PowerPoint and share. Okay, we can see now.
Oh, okay. I get it.
Share again.
Yes.
Yeah, we can see your slides. You can start.
Am I audible, sir?
Yeah, you're audible.
Okay. Okay. A very good evening to all. At the outset, I would like to thank the Bombay Orthopaedic Society for giving me this opportunity. I'm Dr. Soham Ranade, and today I'll be talking about the arthroscopic PCL reconstruction, the single and the double bundle updates. Now, let's have a look at this video. Here we have a young male who is an office employee, and just have a look at his knee. Oops, must have hurt. When we see this X-ray, young surgeons like me are often having many questions. Whether to operate or to conserve, whether to do a single or a double bundle PCL, and what are our graft choices. Now, when did this question arise whether to do a double bundle versus a single bundle PCL? In the International Symposium on PCL Specialists at Florence, there was a question put forward by many rugby, skateboarders, gymnasts, and wrestling people as to something really doesn't feel good in my knee. There is residual posterior translation and there is instability on sudden deceleration. To much surprise, many of these athletes and the sports required a knee flexion of more than 90 degrees. So from here started the journey for double bundle PCL. Now I have taken level 1 and level 2 studies in my literature review. Many RCTs, meta-analysis and systematic reviews. Last 15-year papers have been taken and online engines in the form of PubMed, Google Scholar, Medline have been accessed. The objectives under which I'll be discussing are the anatomical considerations of PCL bundles, the biomechanical studies, the execution difficulties which the surgeon faces, clinical parameters as to subjective and objective outcomes in form of short, mid and long-term follow-ups, associated multiligament injuries, whether the choice changes between a sedentary worker and an athlete, what causes failures, what is the reason for revision PCL reconstructions, a word on graft choices and rehabilitation differences. Now, the PCL consists of basically two bundles, the anterolateral bundle, which is the bigger bundle, and the posteromedial bundle, which is the smaller bundle. Now, these two bundles, they function synergistically in flexion and extension. The anterolateral bundle, as we can see in this video, is tight in deep flexion, whereas the cursor is showing the posteromedial bundle, which is tight in complete extension. Now, these differences are important when we are tightening the double bundle PCL. Laprade et al. Stated that if you are creating the single bundle PCL, make the footprint over the anterolateral bundle and not at the center of the femoral insertion. Because more distal the attachment of the PCL, it's more favorable as opposed to proximal attachment. As much closer to the cartilage, the fiber alignment is much more closer to the native anatomy. In terms of tibial footprint, it is much more compact as opposed to a femoral footprint, and therefore a single tunnel suffices in tibial reconstruction. Now, the biomechanical studies gave us the very important message of codominance, which also supports the phenomena of double bundle PCL. Here we can see three bars in the form of blue, green, and yellow. The blue is the cut PCL, the unrestored one. The green one is the single bundle PCL, and the yellow is the double bundle PCL. Here we can see in increased flexions in 90 and 120 degrees, there is much more posterior tibial translation as opposed to a single bundle PCL. The gap between the single and the double bundle increases. An interesting point to note here is that even though we are tightening the posteromedial bundle at 0 degrees of extension, 0 degrees, it is still helping the anterolateral bundle in complete flexion, in increased degrees of flexion, thereby proving the codominance theory. The execution aspects for surgeons are that in Indians, in Asian populations, we particularly have smaller knees. Therefore, the footprint of the PCL is also smaller. An interesting point to note here is that the dimensions of PCL in Asians are not much different as opposed to that of Western population. So we have the same PCL thickness, but a smaller area to create two bundles, thereby increasing the difficulty level of surgeons. In double bundle PCLs, many surgeons have the problem of tunnel coalescence, a longer learning curve, and donor site morbidity. This begs the question, do we need to burn the bridges for all types of PCL reconstructions for all patients? Maybe not. Regarding tensioning of the bundles, there is differential tensioning which is needed, the anterolateral at 90 degrees of flexion and the posteromedial at extension, which was noted before. To come to talk about the patient-related outcome measures, the subjective and the objective scores. The subjective scores for Lizome and Tegner score are equivocal at short and long-term follow-up. There is not much change. They are not statistically significant. However, the objective scores, the double bundle PCL is better as opposed to a single bundle PCL for a short and long-term duration. Regards to radiological outcomes, it is better for double bundle PCL because it improves the posterior tibial translation is much less for double bundle as opposed to single bundle. Therefore, the radiology wise also it helps for double bundle. Now, what causes these PCLs to fail? An article about the revision PCL reviews stated that associated injury, the PLC injury, a missed PLC was the most common reason, but the second most common reason was a bony malalignment. Now, this bony malalignment was particularly a tibial slope which was flattened or a reduced tibial slope. There are many articles now to note that 1 degree reduction in posterior tibial slope reduction causes an increased 1.3 times the odds of PCL graft failure. Therefore, there is a need to improve the tibial slope so as to avoid early graft failure. There are many procedures which are done now to increase the tibial slope as well. When there are associated ligament injuries in knee dislocations, many surgeons stated that single bundle was preferred by them just because of the fact that there were just too many tunnels. Making sure that they tension and they suture or they reconstruct all the associated broken ligaments as well. There was not much change in the graft choices. The tendo Achilles was used in many, allograft was used in many studies, and hamstring was used for posteromedial bundle, but there is no evidence of superiority of one graft over the other. In rehabilitation, early return to sports was noted in some double bundle RCTs. However, it is not statistically significant. Single bundle gave rise to early osteoarthritis in some cases as opposed to double bundle just because of the fact of posterior tibial translation, increased quadriceps excursion. However, this too was not significant at 15-year follow-up. So the take-home bullets are there is no proven superiority of double over single bundle. Objective scores are better for double bundle. Athletes who require more knee flexion can opt for a double bundle PCL. The choice needs to be individualized and focus should be given to restore the associated ligament injuries and malalignment to reduce the failure rates. These are my references. Thank you so much.
Thank you very much, Soham. I'll invite the judges for questions.
Dr. Mir, I'll take the question first.
Go ahead.
Yeah, Dr. Ranade, a great presentation, very crisply well covered.
Thank you, sir.
Throw light on complications that were mentioned in the articles you read when you did a double bundle or a single bundle as a surgical technique, post-op recovery pattern?
Yes, sir. So the complication rates for a double bundle PCL was increased in time, donor site morbidity, and increased surgical expertise which was required. There was also evidence of tunnel coalescence which was noted by some surgeons. And many surgeons, they stated that in one of the articles, I have found that the complication rate has now started to reduce because of the increased expertise. Initially, surgeons were not much experienced with the double bundle, as this has come into vogue after 2010 per se. I have found articles not before 2010 which stated about double bundle. These were the problems which are faced by the double bundle PCL. And regarding single bundle PCLs, the complication rate was that eventual the objective scores which gave objectively the posterior tibial translation, which was a bit more, and there was some sort of posterior translation or some instability in elite athletes, which because of which the topic of double bundle came into existence. But
Great.
there were no articles which stated increased vascular compromise or neurovascular injuries
Okay.
for double bundle as opposed to a single bundle.
S- Last question from my side. All
Yes.
these studies that you went through, where you had this
Yeah.
patient cohort, one cohort which you did a single bundle was done, and a second cohort double bundle was done. Was the incidence of including an additional procedure the same in both the cohorts, specifically with respect to posterolateral corner reconstructions?
No, sir. In the articles which I have compared, they have excluded in their exclusion criteria, they had excluded multi-ligament injuries, and the systematic reviews and meta-analysis comparing the single and double bundle, they had excluded other forms of injuries or other ligament injuries. Per se, only isolated PCLs were considered in them.
Great. Thanks so much.
Yes.
Hi, Soham, Dr. Amin Rajani here.
Good
Excellent,
evening, sir.
crisp presentation.
Thank you.
And I believe you are from KEM.
Yes, sir.
Who's your guide?
Sir, my guide is Dr. Pradeep Nemade, sir.
Okay, so the presentation skills come from there, I believe. Okay.
Yes.
What I'm trying to ask you is, there are two questions that I want to ask you. One is that in any of the studies that you researched, was there any kind of measurement of the footprint of the PCL on the femoral tunnel measured in any of the studies?
Yes, sir. So the femoral footprint, sir, for the anterolateral bundle is around 112 to 118, and the for the anterolateral bundle, and the posteromedial bundle it is around 68 to 73. So roughly it is around 200 square millimeters, sir, as
In
was seen in the
both the cohorts.
both as in the single and the double bundle.
Yes.
Yes,
Yes.
sir. Yes, sir.
So both
In
they had a 200 millimeters of
roughly
footprint.
because yes, sir, the cohorts or the patient population which the studies had taken, they had taken patients from their respective centers.
Yeah.
So the
So that
point which yes, sir, the ethnic variation which came into
so
existence was
yeah.
between different
So that brings me to my second question. Rather, I would say it is a comment than a question. Is that we are been blindly following Western literature and trying to mimic them.
yes, sir.
I think it's about time that we publish our own studies and let the world
Yes, sir.
follow us, because I think
Correct.
there's a vast difference in the morphology of the human beings in the Western countries compared to the Asian countries. So that is a comment,
Yes, sir.
that's not a question. Thank you very much. Excellent presentation.
Thank you, sir.
I just one question. Soham, it was a great presentation. You had summarized it very well.
Thank you, sir.
What would be your criteria to do a double bundle reconstruction?
Sir, my criteria to do after going through the literature would be a elite athlete who wants early return to sport, who wants to join his sport earlier and wants good knee stability, less posterior translation, and a much sturdier knee, I would opt a double bundle PCL for him. Also, I would opt a double bundle PCL for lax patients when I know that the graft might stretch. There can be a component of rotatory instability, as in patients having a lax knee. For them, I would go for a double bundle PCL.
Okay.
Okay, any questions, Ashish, Darshan?
No, I think good
No.
presentation. So,
Thank you, sir.
Yeah,
Okay.
excellent presentation. No questions. Thank you.
Okay, thank you, Soham. I'll
Thank you, sir.
invite the next contestant, Dr. Zaid Khan. Please upload your presentation. We can start.
Yes, sir. Good evening, everyone. Sir, is my screen visible?
Visible, make it full screen.
Good evening, everyone. Today, my topic is graft choices in ACL reconstruction, current status in 2025. I am Dr. Zaid Khan, and I am an arthroscopy and sport medicine fellow. So, starting with the introduction, why is it necessary? So, ACL primarily functions as a restraint to the anterior tibial translation. So, the goal of ACL reconstruction is to restore the anteroposterior and rotatory knee stability. One of the most important post-operative complication of ACL reconstruction is graft failure. Hence, an ideal graft selection plays a crucial role in the successful long-term outcome of ACL reconstruction. So in this literature, my studies were taken from PubMed, Google Scholar. I have taken systematic reviews and meta-analysis as well as comparative trials which were published in the last 10 years. Now, talking about the ideal graft, what are the properties of an ideal graft? So, the ideal graft should recreate the anatomical and a biomechanical property of the native ligament. It should be easy and safe to harvest. It should have a minimal donor side morbidity. It should have a rapid graft integration, low failure or revision rate, and also should be cost effective. So, what are the choices in today's time for graft choices for ACL reconstruction? We have autograft, which includes bone patella tendon bone graft, hamstring, quadriceps, and peroneus longus. We also have allografts, which includes bone patella tendon bone composites, Achilles tendon, tibialis anterior, tibialis posterior, and synthetic grafts. Now, talking about the most commonly used graft till today, the bone patella tendon bone graft, which is considered as the gold standard and also has the load to failure of 2600 Newton, which is very close to the native ACL. So, talking about the advantages, it is easy to harvest, it has a rapid bone to bone healing, but it has a lot of disadvantages, including the anterior knee pain, kneeling pain, numbness, patella tendinitis, patella fracture, and osteoarthritis. Talking about the hamstring tendon, it is the most common graft used globally and has the highest load to failure of 4500 Newton. It is a reproducible technique. It has small incisions, no anterior knee pain, and options of graft sizing. But talking about the disadvantages, it has an unpredictable graft sizing. It can cause saphenous nerve injury leading to numbness. It can cause residual hamstring weakness, a decreased flexion strength. It stretches out, especially in females. And the last two complications, specifically the post-operative meniscal test. One study was done in a 6-year follow-up in USA by the Moon group, which talked about the incidence and the predictors of subsequent surgeries following ACL reconstruction, which found out that in 3,000 patients in a 6-year follow-up, that hamstring graft has a higher rate of a post-operative meniscal tear. Similarly, hamstring graft also has the highest rate of post-operative infection. This was also a study which was done by Georgi in Greece, which found out that the overall infection rate was 1%, but highest for the hamstring graft. Talking about the quadriceps tendon graft, which has been used commonly in the last few years, it has a load to failure of 2,200 Newtons. It has an advantages of more collagen. It has 3 times more intra-articular collagen than a bone patella tendon bone graft. It has a predictable length and volume, less donor side morbidity, and similar disadvantages like late quadriceps rupture, rectus femoris detachment, and a patella fracture. Now, peroneus longus tendon is very commonly used, so there are less literature on it. But what I have found that the advantages is it has faster knee extension, less anterior knee pain, and it is very easy to harvest. There was a study done by Soham Kiani in 2022, which was a comparative study between the peroneus longus and a hamstring tendon, which was done in 65 patients in a 2-year follow-up, which found there was possible weakness in the ankle eversion after using a peroneus longus tendons. The allografts which are now used are fresh frozen and non-irradiated. There are specific indications where we would like to use an allograft specifically in patients older than 40 years of age, when there are multiple ligament injuries, there is poor harvest from the donor side, if specifically the patient prefers an allograft where there is a revision ACL reconstruction. Synthetic grafts are not being used these days much. I've not included this in my studies. Now, talking about the decision-making factors, what are the decisions to factors to be considered while choosing an ACL graft? The most important are the patient factors. The patient factors, which includes the intrinsic factors like age of the patient, sex of the patient, body mass index of the patient, and the generalized joint laxity. There are also extrinsic factors which includes the occupation of the patient and the sports participation. There are other factors which we should consider like the surgeon's experience and the preference, associate injuries along with the ACL injuries, clinical outcomes and return to sports after the ACL grafts, the graft failure rate, and donor side morbidity. Coming one by one, we would like to start with the age of the patient. In March 2025, Marcelli et al. Carried out a study on ACL graft selection based on age and sport, which was done in Oslo in Norway. He studied the literature which was there in the past 10 years, and he came to a conclusion that in age less than 25 years, autograft has less failure rate compared to the allograft. He also came to a conclusion that in athletes less than 18 years of age, bone patella tendon bone graft was a better choice than a hamstring graft. In age more than 45 years of age, there was no significant difference between the ACL graft used. Similarly, when we talk about the sex, so the females has a higher propensity of graft stretching out. So the failure rate for hamstring graft was much more than the bone patella tendon bone graft. Secondly, we talk about the body mass index. In body mass index, a study was done where they compared the anthropometric measurements with the graft size in ACL reconstruction. It was carried out in 2023 by Loya Salman. They found out and studied the graphs studies which were published till 2020. It was basically 42 studies which they found out, and the patient size of approximately 7,000. So they found out that high BMI patients have a poor hamstring graft. Hence, in patients with high BMI, the bone patella tendon bone graft was preferred over the hamstring graft. And recently, people are shifting to quadriceps tendon, which are more popularly preferred in a high BMI patient. Coming about the sports, so similarly, as I mentioned the previous study, the study carried out by Marcelli et al., he found that in all the athletes, bone patella bone tendon was a preferred graft than hamstring graft. Due to anterior knee pain now, rather than bone patella bone tendon, the quadriceps tendon is becoming the preferred choice of grafts. Now, talking about the generalized joint laxity, a study was carried out by Nathan et al. In July 2021, where he compared bone patella bone tendon graft versus the hamstring graft in patients with generalized joint laxity. He included approximately 9 studies, and he found that the overall failure rate was more in patients with generalized joint laxity, which was itself more for hamstring than for bone patella tendon bone graft. Now we are talking about functional outcomes. I am quoting here 3 studies. One was carried out by Gopinath et al. In April 2025. He studied 9 randomized controlled trials, including 500 patients, and the study was carried out for looked for long-term follow-ups between hamstrings and the quadriceps tendon for a mean follow-up time of approximately 14 years. And not quadriceps, bone patella bone tendon, and they found out that there was no clinical significant difference in the outcome over a long period of time. Similarly, by Medina et al. In June 2025, a study was carried out which included around 2,000 patients, and a 1 year and a 2 year follow-up was done between the 3 grafts, and no significant difference was found out. Similarly, in a study by Dorebs in December 2019, where he compared hamstring and bone patella bone tendon graft, there was no significant difference found out. And while concluding about return to sports, a study
Dr.
was...
Zaid, you have exceeded your time by a minute.
I'm sorry, sir. Can I just complete here?
Yeah, just finish in 30 seconds.
Yeah. So now talking about return to sports, in return to sports also we found that bone patella tendon bone was a favorable graft compared to hamstring graft. Now talking about graft failure rate in the study by Hayback in 21, where she compared around she found out in 194 studies and 152 patients that graft failure was comparatively more for hamstring rather than bone patella bone tendon and the quadriceps graft. I would like to conclude by talking about one final thing about my slide, where I conclude all the tendons and all the factors. So all the 3 graphs were compared based on the knee stability, the functional outcome, and the graft failure rate, and we do not find out any clinical significant difference. These are my references. Thank you.
Thank you very much, Zaid. Open for questions from judges. Avinash sir, you can go ahead.
Yeah, Zain, nice presentation. Just you
Yes, sir.
mentioned about anterior knee pain
Yeah.
with bone patella bone grafts in your penultimate slide. It was up to 79%. Are we in agreement with that? How bad is the anterior knee pain following PTB grafts? That's my question.
So in the majority of the studies which I have found that all of the studies have quoted more than 52%, sir.
Why I'm asking you, my boss in Birmingham did bone patella for 20 years and I used to see his follow-ups and I never saw any unhappy patient. So I myself have gone through the literature. So the literature is very, very variable. It is 4% to 70%. So in some centers they have reported more. And the interesting part is in the latest editions of Journal of Knee and Shoulder Surgery, in the ISACOS, there is an article which is mentioned that the anterior knee pain is very, very brisk and very, very short period. Over a period of time, it completely recovers. Okay, and that's the reason you
Yes, sir.
don't have unhappy patients with anterior knee pain following a bone patella bone. So this 80% will scare anybody away to use a bone patella bone graft. You see, of about 79% which you have shown. Just a comment I'm making. You can read
Yes,
more
sir.
about it. Thank you.
Yes, sir.
So
Hi,
is there
Zaid.
one question from my side?
Okay.
When you talk about quadricep tendon, uh,
Yes, sir.
which part specifically about the quadricep tendon? Because I did not see any discussion about which part of the quadricep. Are we talking about mid quadricep? Are we talking about superficial quadricep? So if you could throw light upon that, when you say quadricep tendon, we can harvest graft from different parts of the quadricep tendon.
Yes, sir. So this in the literature, what I have read, sir, they have all talked about the mid part of the quadriceps. There was no specific studies comparing about the graph different types of graph selections in quadriceps. So I have not read much about that, sir.
And any referencing you did about quadricep tendon with a bone plug from the patellar side or isolated free quadricep tendon graft?
So the studies which I have quoted, sir, all of them used free quadriceps, soft tissue quadriceps, and none of them did any comparison with the bone plug on the patella sides.
Okay, thanks.
Thank you, sir.
Zaid, nice presentation.
Thank you,
I
sir.
just want to give you a few tips. Too much of information in very little time. Try and make your presentations a little more crisper, and
Yes, sir.
you'll do very well.
Thank
I
you.
have two questions for you, rather one question. I saw all the studies that you have done. We Indian authors have also published a lot of literature on quads tendon, peroneus longus, and hamstrings. Did you come across any articles from any of our Indian colleagues uh, about the graft options?
Sir, no, sir, I have not taken any study from the Indian author
Why?
in
We are
my.
also good researchers. We also do a lot of publications. Let's
Yeah.
not follow the international people. Let's do a
Yes, sir.
little bit and study for the Indian population, which has been published by our Indian colleagues. Maneet Arora has done an excellent study on peroneus longus, about I think 2,000 patients. I've had a study published in Indian Journal of Orthopaedics with 400 patients for peroneus longus. I think the budding youngsters should include our studies, our Indian studies in your presentation.
Yes,
It'll
sir.
make a hell lot of a difference, and your perspective will change because we are talking about our patient demographics. Yeah. Thank you, but very nice presentation.
Thank
Yeah.
you, sir.
Thank you very much. Any other questions, Dr. Ashish, Dhar sir?
No, I think a very good presentation. Good presentation too. As
Thank you, sir.
I agree with, too much information. That's the reason probably you have to rush in with your slides.
Yes, sir.
Good overall.
Thank you, sir.
No comment. Thank you.
Thanks. With that, we come to an end to the session. I'll invite Secretary of Bombay Orthopaedic Society, Dr. Ashish Phadnis, for vote of thanks and closing remarks.
Thank you very much, Ashok. And first of all, thank you to all the participants for having enrolled here. And we are quite pleased to see the enthusiasm with which we are getting applicants for this unique opportunity that Dr. Dhar has sort of, conceived, and we are taking it forward. So thank you very much for all the participants. All of you have done a very good job. And remember that this is just the first step towards, making your presence felt and sort of trying to understand what the literature is and presenting it on a forum. And I would also like to thank my dear friends, Dr. Amin Rajani, Dr. Mihir Patel, and Dr. Avinash Mahale for agreeing to our request to moderate the session, mark the candidates, and give them a positive feedback about everything related to the topic. Lastly, thank you very much, Dhar sir, for this innovative idea. And our friends at OrthoTV, I think Poonam and Rishi both were there. And thank you very much to Dr. Neeraj Bijlani and Dr. Ashok Shyam, who sort of, tirelessly see every year this event just, goes through very smoothly, and they conduct it very well. Lastly, I would also like to invite all of you to participate in the various BOS activities. I know most of you are, all of you are members, but one thing that Dr. Gautam Zaveri did not mention was there is a sports day that is going on. Being arthroscopic surgeon, I'm sure all of you are into some kind of sports or so. So I would expect all of you to be there, and we've got a lot of options, whether it's playing carom or cricket. We've got everything from carom to cricket on that particular day. So make sure you register there, and I would hope to see you all there. Thank you very much.
Thank you very
much, Ashish.
Thank you.
Thanks a
Thank
lot.
you.
Dhar.
Good night. Thank you, Ashok.
Bye.
Thank you, Dhar sir.
Thank you.